This session is the COVID-19 surveillance in Indian country. And as I said before, our presenter is Scott Erickson. He's an epidemiologist at the Urban Indian Health Institute, which is a division of the Seattle Indian Health Board. He received his Master's of Public Health and Epidemiology from the University of Washington School of Public Health. Prior to beginning work at the Urban Indian Health Institute, Scott's research focused on improving hospital discharge outcomes of pediatric patients with severe traumatic brain injury. At UIHI, Scott has worked on the Community Health Profiles and Diabetes projects and currently serves as lead epidemiologist on projects analyzing national COVID-19 case surveillance data. His work contributed to the generation of the report titled Data Genocide of American Indians, Alaska Natives in COVID-19 Data, which was designed to spotlight the erasure of American Indians and Alaska Native persons from COVID-19. So without further ado, I'm going to turn it over to you, Scott.
Wonderful. Thank you for that introduction, Christy. It looks as though you need to enable me to share my screen. There we go. All right. Okay. I hope everyone is having a great week. My name is Scott Erickson, and as Christy introduced me, I am the COVID-19 epidemiologist currently working at the Urban Indian Health Institute on our national COVID-19 case surveillance data. Since the start of the pandemic in January 2020, the Urban Indian Health Institute has been performing surveillance duties on COVID-19 data that has come to us from the Center for Disease Control and Prevention. The purpose of this conversation is to give you an overview of what those activities have been, what the current state of COVID-19 surveillance in Indian country is, and what our future steps moving forward are. First, the Urban Indian Health Institute is one of 12 Indian Health Service Tribal Epidemiology Centers, or TECs, and is a division of the Seattle Indian Health Board, which is an urban Indian health program. We have been serving urban American Indian and Alaska Natives, which I will abbreviate to AIN for the remainder of this presentation, since 2000. UIHI serves to improve the health of American Indian and Alaska Natives by identifying and understanding health disparities and resiliency, strengthening public health capacity, disease surveillance and disease prevention, health promotion, and disease prevention grounded in Indigenous methodologies. Urban Indian health programs are 41 nonprofit 501c3 programs nationwide funded directly by IHS. These programs are spread across the nation, as I have presented in this graph here, including a map that shows the percent of a population in a given area that identifies as American Indian or Alaska Native. These programs serve a total of 2.2 million American Indian Alaska Natives across 115 counties. This is one of our service area definitions. The second service area definition that we use is urban areas. So an urban center is defined by the National Center for Health Statistics, urban-rural classification scheme. These correspond to counties with populations greater than 50,000 persons. These counties contain 5.4 million American Indian Alaska Natives, which corresponds to 76.4% of all individuals who identify as American Indian Alaska Native, alone or in any combination. The COVID-19 timeline, I want to give an overview of this to anchor ourselves as we move through this conversation. In January 19th, the first confirmed COVID-19 case occurred in the US. Then as we move forward in April 2020, UIHI launched the National COVID-19 Surveillance Survey. In May, UIHI was provided with access to Washington's COVID-19 case surveillance data. And then in July, UIHI was provided access to the Center for Disease Control and Prevention National COVID-19 case surveillance data. It wasn't long after that, the UIHI identified deficits in that Center for Disease Control and Prevention data. And then in February 2021, we published the data genocide report documenting those deficits in the data. And since then, we have been undergoing work with the Center for Disease Control and Prevention to understand that data and improve. Starting with the National Urban Indian Organization COVID-19 Surveillance Survey. As part of the nationwide response to COVID-19, UIHI launched a national COVID-19 surveillance survey in April for IHS-funded urban Indian organizations across the United States. Each week, urban Indian organizations are asked to submit data on COVID-19 screening, testing, demographics, and risk status of patients positive for COVID-19, vaccinations administered, PPE supplies, and staff exposure or illnesses. This surveillance survey provides data to document the impact of COVID-19 on urban American Indian, Alaska Natives, and the health programs that serve them. Using this surveillance data, UIHI sends the National Council of Urban Indian Health a weekly report to inform their advocacy at the federal level. UIHI also has developed individual surveillance reports for each UIO that has submitted data to support their COVID-19 response effort and document the incredible work of UIOs across the nation. In addition to those, we also send out monthly aggregate surveillance reports to all participating UIOs to provide timely COVID-19 data that can be used for advocacy, grant applications, and program development. UIHI's COVID-19 surveillance activities in Washington State include a monthly report on COVID-19 among American Indian Alaska Natives using the Washington Disease Reporting System, or WDRS, the database in which public health authorities in Washington receive, enter, and track information on reportable diseases. This monthly report provides information on the disproportionate burden of COVID-19 incidents, hospitalization, and mortality among American Indian Alaska Natives in Washington State as compared to non-Hispanic whites. It also examines the course of the pandemic over time and across countries, with an emphasis on the service areas of urban Indian organizations in Washington State. This report also highlights missingness of racial information by county, as with our other COVID-19 surveillance work. This report is sent out each month to urban Indian organizations in the state of Washington to provide timely surveillance data, which can be used to inform their COVID-19 response efforts, including local and state advocacy. Moving on to some of our national surveillance work, we have staff that have published in 2 separate morbidity and mortality weekly reports. The first report being Hatcher and et al., which was published in August, which covered 23 separate states and covered all American Indian Alaska Natives, regardless of urban or rural county status. In that report, they identified that the cumulative incidence of laboratory confirmed COVID-19 was 3.5 times higher than among non-Hispanic white persons. The second morbidity and mortality weekly report that was published with UIHI staff was Arizola et al. In December. This report found that age-adjusted COVID-19 associated mortality among American Indian Alaska Natives was 1.8 times that among non-Hispanic whites. These reports only contain information for 23 states and 14 states respectively. The reason behind the first paper was that the 23 states were the only 23 states that met data quality criteria to be published. And this is one of the fundamental lessons that comes out of the COVID-19 pandemic, is the strain that pandemic has put on public health organizations, which has resulted in immense data quality issues. Overall, the reporting of COVID-19 case information to the CDC is poor. Not only do cases need to be investigated to assign race and ethnicity to those cases, but those cases also need to be sent to the CDC in a format in which race is included in their definition. As of today, only 64% of COVID-19 cases are reported to the CDC with complete race and ethnicity. The map I've included here shows all urban areas and their overall percent completion of race and ethnicity as to whether it was greater than or less than 70% back in January 20th of 2021. The reason we use this cutoff is that was the cutoff that the previous Hatcher et al. MMWR article used to assign whether or not a county was providing enough data to be deemed eligible for inclusion in the study. As you can see from this chart, the percent completion of race and ethnicity of COVID-19 cases varies significantly by state as well as by county. Some other organizations have highlighted this information as well. This is a figure from Google's Health Equity Tracker. I've included a link to it on this slide. And this Health Equity Tracker shows the relative proportion of COVID-19 cases with unknown race or ethnicity submitted by that state. As you can see, several states are completely omitted from this analysis, including Texas and North Dakota. Those states have submitted next to no COVID-19 cases to the Center for Disease Control and Prevention, as well as several other states are not only not submitting cases, they're not submitting any cases with racial information. This is something to keep in mind as we move throughout the rest of this presentation, that the data we are showing does not provide coverage for the entire United States. To document this issue, the Urban Indian Health Institute developed a report titled the Data Genocide Report. It was a report card grading the United States quality of racial data and their effectiveness in collecting and reporting data on American Indian Alaska Native populations. The key metrics we included in this report were the inclusion of American Indian Alaska Natives on state dashboards, the percent of cases with complete racial data on state dashboards, the percent of cases reported to CDC by states, and the percent of cases with complete racial data reported to the CDC. To keep things simple, we made sure that each of these metrics contributed a quarter of the overall grade that a state received. Overall, the key.
I hate to interrupt you for just 1 second. I think we can see the notes page, and I'm worried about the recording when people go back to view it. Could you go to maybe just the full slide page?
The full slide page. Oh no, was I sharing the wrong screen?
That's okay. We could read
no. I'm so sorry, everyone.
Right,
well, at least you all got to see my notes.
Hey, my notes sometimes look crazy, so, but thank you. I hate to interrupt you.
No, thank you for interrupting. And now getting back into the swing of things, now that my notes are hidden. The key findings from the Data Genocide Report are as follows. The overall score that the US received on the reporting of race and ethnicity during the COVID-19 pandemic was a D+. I joked to Abigail that the US wouldn't have passed high school with this grade. 22 states had a failing grade, which for my school was less than a 60%. 18 states reported less than 70% of confirmed cases to the CDC. This is before even the issue of whether or not they collected race and ethnicity was included in that metric at all. 14 states did not include American Indian Alaska Natives on their dashboard. And this included states where, for example, American Indian Alaska Natives were lumped with categories such as other or unknown racial groups. This is because those metrics do not result in meaningful statistics. The example I like to use most for the uselessness of that statistic is in South Carolina, where to this day, their COVID-19 dashboard lumps American Indian Alaska Natives in with Asian and Native Hawaiian Pacific Islanders. Those demographic groups share little to nothing in common with each other, and as such, the lumping those statistics together masks the effect of those statistics for all of the groups. The 5 states with the lowest overall grade in the COVID-19 pandemic were Texas, New York, New Hampshire, Maryland, and West Virginia. These states had a complete lack of data in both the Center for Disease Control and Prevention data, as well as data that was disseminated via their own dashboards. To this effect, the data that we are present moving forward almost completely lacks any information for those states at all. The National COVID-19 Vaccination Survey. In December 2020, UIHI launched a national survey on knowledge, attitudes, and beliefs of COVID-19 vaccines. 1,435 American Indian Alaska Natives from across the US responded, more than 300 different tribes across 46 states. 75% of participants reported willingness to receive a COVID vaccine, which is higher than 64% in the general US population from another poll. The primary motivation for participants who indicated willingness to get vaccinated was a strong sense of responsibility to protect the Native community and preserve cultural ways. The most frequently reported reason behind hesitancy was around how fast vaccines move through clinical trials. As a result of this work, we not only created a public report, but also community-informed vaccination campaign to help American Indian Alaska Natives make an informed decision around COVID vaccination. The resources, like the poster and vaccine fact sheets and masks here, are culturally attuned and informed by our survey findings. For example, our survey found that elders were one of the most effective ambassadors for vaccine promotion. These resources have been shared with urban Indian health programs and other Native partners to help in their effort to support vaccination across Indian country. Another aspect of work that we've been focusing on is ongoing data quality issues. This particular analysis focuses on the issue of the collection of multiple racial identities. This is a set of graphs that I put together to share with the Center for Disease Control and Prevention over concerns that I had that despite the case surveillance form allowing for Office of Management and Budget racial categories where each individual can have any of 5 races of including one or more racial identities, as well as they need to collect race and Hispanic ethnicity. I had concerns that assumption was not holding true for all states. And so I put this analysis together where I looked at the percentage of all American Indian Alaska Native residents within an individual state per the 2019 census estimates, and that corresponds to all American Indian Alaska Natives alone or in any combination, all ethnicities. And then I compared that to 3 individual groups, those that identified as non-Hispanic, those that identified as only having one racial identity, and those that identified as having one racial identity and being non-Hispanic. I then plotted that on the x-axis, and then I compared that to how the data was coming to us in the CDC COVID-19 case surveillance data on the y-axis. To break down these charts a little further, each point on the map can be interpreted as where on the x-axis is what percentage of COVID-19 cases would we roughly expect to have that individual identity. And on the y-axis then is where the COVID-19 data shows that they ended up. What this result revealed to us is if you look at the %1 racial identity graph, those are all individuals where they only had one listed racial identity for that COVID-19 case. They didn't collect any other racial information at all. All other fields were blank. We found that 7 states were presenting 100% or 99.9% of COVID-19 cases to the CDC for American Indian Alaska Natives with only one racial identity. We ended up adjusting for, we excluded states with less than 50 American Indian Alaska Native cases, and the CDC subsequently investigated these states and found that the 7 states flagged here, Georgia, Florida, New York, New England, North Carolina, Arizona, and South Dakota. All of those states only had COVID-19 cases listed as one racial identity. The underlying issue in this situation varied depending on the state, but for most of these situations, it was due to an interoperability error where the COVID-19 cases that went into their system, while they might have initially been collected with multiple races, that multiple racial identity was stripped at some point in the data transmission process from the point of laboratory connection to the state database and then to the CDC. At some point in that process, that chain failed for those 7 states. We flagged that information to the 2 CDC staff which investigated it with their state partners, and then they are planning to work on some data modernization initiatives that should hopefully alleviate these issues in the future. A secondary issue that I wanted to examine was the collection of both race and ethnicity. This has been a longstanding issue in many surveillance efforts where if you collect either a race or an ethnicity, oftentimes ethnicity is used as a race and so it is not collected. What I did here is I looked at all of the individuals of COVID-19 cases for a state, and then I looked at all of the individuals where race or ethnicity was collected. I then categorized those into 3 individual buckets. Those for whom race and ethnicity was completed, which corresponds to a green line, the individuals for whom race was left blank, and the individuals for whom ethnicity was left blank. The primary takeaway from this analysis is that there are some states where even if they were collecting either race or ethnicity, 50% of the information or more might be missing. California is a prime example of that, where you can see that even though among those who had race and ethnicity collected, only 50% of them had both race and ethnicity collected, and up to 40% of individuals had their race left blank. Those 40% of individuals for whom race and ethnicity was collected in California, for whom their race was left blank, we are unable to assign them to having an American Indian or Alaska Native identity. Both of the issues that I flagged here, the collection of multiple races and the collection of both race and ethnicity, impact American Indian and Alaska Native populations, especially because American Indian and Alaska populations are some of the most multiracial and multi-ethnic populations in the United States. The inability of current data systems to address these issues is to the detriment of collecting high quality COVID-19 and all future surveillance efforts on American Indian and Alaska Native populations. Keeping those facts in mind, I'm going to transition into discussing some of our current COVID-19 surveillance metrics. The scope of the analysis that I'm going to present today focuses on urban counties alone, all urban counties in the US, all 50 states. The definition that we are using for this analysis is due to the issues I just presented on the collection of multi-race and the collection of multiple ethnicities corresponds only to American Indian, Alaska Native alone, non-Hispanic individuals. The date range we are presenting here will be focused between January 20th, 2020 and August 25th, 2021. The percentage, and I wanted to touch on the changing of the COVID-19 racial data quality over time briefly. Looking over time, and on the y-axis here, I used the New York Times COVID-19 case surveillance data that is universally available as our metric of the true number of COVID-19 cases within a county. We took the percentage of COVID-19 cases with complete race and ethnicity, and then divided that number by the total number of New York Times cases available on a given day to receive the relative amount of COVID-19 cases that were sent to the CDC with complete race and ethnicity. Since the start of the COVID-19 pandemic, we can see that generally things haven't changed on an absolute scale significantly. From my perspective, if depending on your start point for when you start looking at the data, you can see a minor increase of, say, from between 40% to roughly 50% currently, which over something like 12 to 15 months, which corresponds to a rough increase in the percentage of racial data available of around like 1% per month, which to me is positively glacial. But In terms of analysis that is going to be presented on more current metrics, the COVID-19 case surveillance data is at the best it's ever been. Keeping that in mind, I'll move into some current cumulative counts. Among urban American Indian and Alaska Native individuals, there have been a total of 124,785 cases, 11,078 total hospitalizations, and 2,955 total deaths. The map I present here corresponds to a shaded map presenting those cumulative counts. The hardest hit states by total number of urban American Indian Alaska Native COVID-19 cases are Arizona with 23,000 cases, Oklahoma with 15,000 cases, and New Mexico with 15,000 cases as well. Moving on to age-adjusted rates. The age-adjusted rate for cases was 8,719 cases per 100,000, 774 per 100,000 for hospitalizations, and 214 per 100,000 for deaths. The hardest hit states by age-adjusted cumulative incidence were Arizona with 14,000 per 100,000 individuals affected, New Mexico 14,000 per 100,000 individuals affected, Utah 14 per 100,000 individuals affected, and South Dakota 12,000 individuals per 100,000 infected. The relative risk of COVID-19 outcomes among American Indian and Alaska Natives relative to non-Hispanic whites was 1.78 times higher likelihood of being infected with COVID-19 relative to non-Hispanic whites, 3.71 times the likelihood of being hospitalized with COVID-19, and 2.76 times the likelihood of dying from COVID-19 relative to non-Hispanic whites. As we go on, we can see that these relative risks have declined over time. And so the initial burden happened early on, and that initial burden resulted in a huge spike in cases, but I'll get into that as we get there. This page is a little intimidating, but give me a little time and I'll go into it. These three plots correspond to county by county inspections of COVID-19 incidence and disparities. On the y-axis, I plotted the age-adjusted cumulative incidence per 100,000 of COVID-19 and American Indian and Alaska Natives on the x-axis. I then put a dashed line corresponding to the national non-Hispanic white age-adjusted cumulative incidence of COVID-19 per 100,000 individuals. Every point to the right of that vertical line corresponds to a county where the American Indian Alaska Native population experienced a higher rate of COVID-19 infections compared to the national non-Hispanic white average. Any point to the left of that vertical line corresponds to a county that was not hit as hard. On the y-axis, I plotted the within county relative risk of COVID-19 infections of comparing American Indian and Alaska Natives to non-Hispanic whites. The dashed line corresponds to a relative risk of 1, which means that that county was not hit any harder in American Indian and Alaska Native populations relative to non-Hispanic white populations. I plotted these 2 points so I could make quadrants on the graph. Any point that is in the bottom left quadrant corresponds to a county that was hit less hard than non-Hispanic whites on average nationwide, and also fared better than non-Hispanic whites on average nationwide. Conversely, any quadrant in the top right corresponds to a county that was hit harder than non-Hispanic whites nationwide and harder to non-Hispanic whites within their own county. The point I wanted to make with this graph is that not only do American Indian and Alaska Natives live in counties that were inherently hit on average harder than non-Hispanic whites nationwide, but that they were hit harder than non-Hispanic whites living within their own county. This is just a visual way of adjusting for correlation. And as we can see, many counties fared very poorly in terms of their relative risk compared to non-Hispanic whites, which even greater than the numbers I presented on the previous slide, which for case incidence corresponded to around 1.71, we can see that many counties fared with up to 3 times as bad as non-Hispanic whites within their own county. We can see these results reflected again when we look at the similar scatter plot that corresponds to hospitalizations in the top right, which has an almost even exaggerated effect relative to COVID-19 cases. And this effect is again mirrored when we look at COVID-19 deaths within counties. The discrepancy that I wanted to highlight among these graphs is that the case rate looks, the overall trend of the case rate scatter points relative to the hospitalization and death scatter points is more biased towards a lower relative risk. And this is reflected in these aggregate numbers here of 1.78 times likelihood to be infected with COVID-19 versus the 3.71 and 2.76 times likelihood to be hospitalized and die from COVID-19. One rationale we have explored behind this is being fleshed out in a later study, but we believe that for individuals who are infected with COVID-19 who are American Indian and Alaska Natives, that infection is more likely to put an individual in a hospital or more likely to be fatal relative to non-Hispanic whites. This may be due to a number of reasons, including underlying medical conditions or increased severity of exposure. Moving on into an overview of demographics of COVID-19 infections among urban American Indian Alaska Natives. The group that had the highest cumulative incidence of COVID-19 infections were individuals who were 20 to 44 years of age. And that final group should be 45 plus, but that is a minor typo. But however, we can see that despite the cumulative incidence being highest amongst that middle age group, we can see that the relative risk across those age groups does not vary tremendously, except among that higher age group, which indicates that maybe the elders in the community or those who were greater than 45 years of age were able to shelter in place more effectively and avoid COVID-19 infections relative to younger age groups. Among the sexes, we identified that female urban American Indian Alaska Natives had a higher cumulative incidence of COVID-19 relative to male urban American Indian Alaska Natives, with a cumulative incidence of 9.4 cases per 100,000 individuals relative to 8.0 thousand cases per 100 individuals. The relative risk was slightly greater among female urban American Indian Alaska Natives at a rate of 1.82 relative to non-Hispanic whites compared to a rate of 1.72 among male urban American Indian Alaska Natives. Before we transition onto the longitudinal trends that we've identified in the COVID-19 analysis, I wanted to root us once again in the data quality that we've been seeing. This chart corresponds to flat numbers of COVID-19 cases, so not per 100,000, but rather just the total number of COVID-19 cases as reported by the New York Times, which is labeled in black, and in green, the CDC cases with complete racial data. As we can see early on in the pandemic, the CDC cases with complete racial data did not respond well to the surges that happened early in July and then again in December, where we can see that those surges completely left the capacity of health departments behind to send that data in. We have enormous gaps in those areas in terms of our overall understanding of the true burden of disease. And as such, that's important to keep in mind moving forward, that even though the current surge is incredibly large, the values that we will see in the incidence graphs moving forward will not reflect the true extent of the disease as much as we are seeing now, because with the current surge, we look as though we're capturing around 50% of those cases, where in the earlier surges, we were capturing maybe a third. Moving on to the COVID-19 surveillance, looking at longitudinal trends for cases. This information corresponds to all urban locations. Once again, starting in May 2020, we have one line plotted for the incidence of COVID-19 infection among American Indian Alaska Natives in green, and one line plotted for non-Hispanic whites in gray. You can see that early on, the incidence of COVID-19 infection has remained high among urban American Indian Alaska Natives compared to non-Hispanic whites throughout the entirety of the pandemic, with only one period of time where American Indian Alaska Natives rates of COVID-19 fell below that of non-Hispanic whites. These discrepancies in the COVID-19 incidence appear to be exacerbated during the large surges, where during large surges of COVID-19, urban American Indian Alaska Natives might not be able to shelter in place as much as non-Hispanic whites are. Additionally, we can see the effects of the most recent surge coming into play with the surge beginning in July of 2021 and continuing to peak in August. There is a period of time where we have a lack of data flowing from the states to the CDC over the most recent timeframes. As such, we don't know the current trajectory of the disease during that box that's outlined in gray. Hopefully it follows that trend. That would be very nice, but we'll have to wait and see. Moving on to COVID-19 hospitalizations, and I'll be switching back and forth between this graph and the graph covering COVID-19 cases because I feel it is informative. We can see that once again, the rate of COVID-19 hospitalizations has remained much higher among American Indian Alaska Natives compared to non-Hispanic whites throughout the duration of the COVID-19 pandemic. However, as we compare these two graphs, looking at the hospitalization graph first, and then going back to the case graph, we can see that the discrepancy between the hospitalization graph and the case graph is larger in that initial surge, where urban American Indian Alaska Native populations bore an even larger brunt of hospitalizations relative to their incidence rate. And however, since that rollout of the vaccine that happened in January 2021 and the very impressive uptake among the vaccine among urban American Indian Alaska Native populations, we can see that that hospitalization rate has fallen significantly and is beginning to get much closer to the non-Hispanic white rate of hospitalizations. One thing to keep in mind on this hospitalization graph as well is that there's an even larger period of time where states need to collect the information on hospitalizations to send it into the CDC than compared to just collecting the cumulative case index. As such, that gray bar might need to be extended even further to where that initial peak in August might seem to be falling off. Once again, fingers crossed that the hospitalization trend continues to fall like that for urban American Indian Alaska Native populations. Moving on to the longitudinal trends in death, we can see that these numbers mirror the non-Hispanic white rate for death much more closely than cases and hospitalizations do. We do see exacerbations of the trends for deaths in both the initial surge in June and then the later surge in winter surge in 2020. However, since that time and the rollout of the vaccine, we can see that American Indian Alaska Native rates of COVID-19 deaths have plummeted to being approximately equal with a non-Hispanic white rate of death, which is very encouraging. Moving on to some surveillance events in the last month. The cumulative count of urban American Indian Alaska Native cases in the past month has been 6,094 total cases, 284 total hospitalizations, and 20 total deaths. We identified the greatest incidence of COVID-19 cases in the past month in Alaska at 1,400 cases in the past month per 100,000 individuals, and in Oklahoma with 1,000 cases per 100,000 individuals. This is a plot that we put together looking at the a correlation of the 1-month COVID-19 incidence among American Indian Alaska Native communities, plotted on the x-axis, compared to the overall county percentage with 1 dose administered. So that y-axis is not race specific. It's not specific to American Indian Alaska Native individuals, but rather it corresponds to the entire population. That's important to know moving forward, as it's easy to look at this plot and slap a line on it and say that counties with lower percentage of the county with 1 dose administered correspond to higher American Indian Alaska Native COVID-19 incidence per 100,000. But it's important to remember that the vaccination percentage numbers presented here are for the county overall. What we can see, however, is that there are some counties where there is room for improvement in COVID-19 vaccination rates among a county overall. The top 10 counties with the greatest incidence per 100,000, of those top 10, 7 of those counties were in Oklahoma. All of those counties had vaccination rates greater than 50%. 1 county was in North Carolina, 1 in Oregon, and 1 in Alaska. Notably, only 3 counties had greater than 10 COVID-19 cases among American Indian Alaska Natives greater than 65 years of age, which is a great accomplishment. Moving on towards next steps for UIHI and building out data quality. Equity will not be achieved in COVID-19 response or vaccinations until race and ethnicity is properly collected and reported. The ongoing erasure of American Indian Alaska Natives in reports, publication, and literature results in an underestimation of the true severity of morbidity and mortality, inadequate public health programs and activities that are non-responsive to American Indian Alaska Native communities, inequitable allocation of resources for disproportionately impacted communities, incorrect and limited understanding of racial health disparities, and the perpetuation of health disparities due to misinformed, data-driven decisions. We have some recommendations for improving the collection and reporting of race and ethnicity. State and federal government agencies have the most power to enact and enforce data quality policies and standards. We recommend mandating the collection and reporting of race and ethnicity for all COVID-19 cases, and subsequently enforcing the collection and reporting of race and ethnicity by providing resources, incentives, and penalties to organizations. We recommend resourcing the overall public health surveillance systems nationally, standardize the collection and reporting of race and ethnicity by UIHI best practices, avoid grouping populations into homogenizing categories such as other, unknown, or multiracial. Before I wrap up, I wanted to touch on some of the future work. We have a very exciting set of tools coming out in the subsequent coming weeks, of which we'll be planning to announce to Urban Indian Health Program directors this week. And we will be planning a webinar to describe the tools and methods to use these reports in the future. The first of these tools is the COVID-19 data dashboard that the Urban Indian Health Institute has been putting together. The COVID-19 dashboard covers all CDC COVID-19 data coming to UIHI. This corresponds to all CDC COVID-19 data for the country. This data will contain information aggregating by urban centers in all counties nationwide and state by state. This data will be updated weekly, providing surveillance tools available to urban Indian health programs that they can use on a week-to-week basis. Much of the information that I presented today comes from that analysis. You'll be able to look at cases, hospitalizations, and deaths, look at cumulative counts of each of those statistics, the rate for the past 4 weeks, get easy access to some of the longitudinal trends that I provided in this report, as well as easy tracking of the racial data availability that corresponds to your individual state that will allow you to make sense of the quality of the data you are using to make your decisions. The second tool we will be launching are COVID-19 Urban Indian Health Program individual site reports. The COVID-19 reports are tailored to service areas containing one or more urban Indian health programs, and they contain a deeper dive of COVID-19 statistics specific to the counties served by urban Indian health programs. These statistics include things like age-adjusted rates, relative risks, and numbers that could be used for grant writing or the requesting of additional supplies. We are also planning several additional future analyses. We are working with the Council of State and Territorial Epidemiologists on analysis focusing on severe outcomes using data collected directly from state partners. This data will allow us to look at things like underlying comorbidities and their association with COVID-19 outcomes, as well as providing access to the best possible data that is available on American Indian Alaska Native COVID-19 hospitalizations and deaths. We are also working with CSTE staff on an analysis looking at barriers and facilitators to the collection of race and ethnicity. We are also planning a journal article examining COVID-19 rates specifically among urban American Indian Alaska Natives, also including a time stratified analysis looking at the difference between the relative risk of COVID-19 among American Indian Alaska Natives to non-Hispanic whites pre-vaccine availability and post-vaccine availability. We will also be launching a report examining how data quality has changed nationwide since the first data genocide report, including metrics for the efficacy of states in presenting COVID-19 surveillance specific to vaccination numbers by race and ethnicity. That concludes my presentation for today. I wanted to thank you for listening and attending this presentation. If you have any questions that you would like to reach out to me specifically at, please feel free to contact me at the email listed here. I'll open it up to question and answer now.
Scott, thank you. I do have one comment, more of a comment than a question. First of all, the work that UIHI has done on this is fantastic and comprehensive and so helpful to the tribal epidemiology centers. I know when we first received the data and we saw the percentage of missing data for race and ethnicity broken down by state early on, I shocked. You know, I've been working in Indian country for a long time. Fortunately, it's particularly bad in the eastern states that
I just lost Christy.
So did I.
Yep. I'll wait for her to come back, but while we're waiting for her to rejoin us, are there any questions that anyone else has?
My apologies. I had a connection issue. Important. Are there any additional questions?
Yeah, Christy, I wasn't able to hear the comments you had, other than the fact that the racial data quality is especially bad in some of the southeastern states. Was there another point you wanted to expand on there?
I think we lost her again.
Yeah, I think we lost her. I do want to expand on that point on the southeastern states right now. The primary burden of COVID-19 that's happening in the country right now is in those southeastern states. And it really underscores the effect that the lack of reporting by some of those southeastern states has on the data. Florida, for instance, is one of those states that I flagged that does not report more than one racial identity per individual to the CDC. And so in addition to having their already poor reporting of race and ethnicity to the CDC, we have a poorer quality data that's coming out as well. So in many instances in this current Southeastern kind of cluster of cases that are coming out, we're operating blind for surveillance information in many respects. Thankfully, I believe Oklahoma has a good quality of data coming out of it. And so a primary urban American Indian Alaska Native population center has good high quality surveillance statistics coming out for that state, which is a silver lining to all of this. But that Southeastern cluster, especially with Texas, who is not sending in any racial information at all to the CDC, leaves us operating blind.